Hello and welcome to A Blind Date with Knowledge, the podcast shining a spotlight on research within the North East region. My name is Stephen Liggett, and in this episode I had the great pleasure of sitting down with Professor Caroline Wroe, current Clinical Director of the National Institute for Health and Care Research, Clinical Research Network in the North East and North Cumbria. As well as this amazing role, Caroline has had a hugely successful career in nephrology and renal medicine as a consultant kidney specialist. I was first introduced to Caroline when she was the research and development lead at South Tees Hospitals, and I had just started in my pathology research role. Caroline was a fantastic source of support and inspiration with a huge passion, enthusiasm and drive for research, something still very evident in this conversation. So please keep listening for stories from Caroline's research journey, from principal investigator and chief investigator, to her work with the pioneering Living Kidney Donation Network, and her ongoing commitment to tackling health inequalities via the homelessness organisation Oasis Community Housing. All links and contact details, including how to access the other podcasts I discuss with Caroline, will be given out at the end of this episode. I really hope you enjoy this discussion with one of the North East's most influential research figures. Firstly, thank you very much for your time, Professor Caroline Wroe. It's a great privilege to get to speak to you this afternoon. So as I've mentioned in the introduction, you've had many research roles that have made a huge impact on kind of the research in the North East, from being a principal investigator and a chief investigator as a consultant kidney specialist, to your amazing work in living donations in kidney transplants, and now as the clinical director at the Clinical Research Network in the North East and North Cumbria. So I guess my first question for you, or first questions, I think would be, what first attracted you to research as a kind of career? And is there something special about research and the research environment that has kept you so engaged and active?
Well, first of all, thank you for having me, and it's a pleasure to come and join you. I think I've always had an inquiring mind, and that's what my mum used to describe me as a little kid. I was always interested in stuff worked, and why things are the way they are. And one of my first training consultants, a guy called John Main, who has now retired, but was really helpful in encouraging me to think about research in clinical settings. And when I was training as a kidney specialist, I did a PhD in human molecular genetics, and I really enjoyed that. And when I qualified, I ended up not staying in academic pathway, but actually going into full-time clinical work, but still had that kind of interest and inquiring mind. And John encouraged me to consider becoming a principal investigator and supported me in doing that. And I picked, of all the daft things to pick, a really complicated clinical trial involving a medicine that was quite a new infusion medicine. And it was for a rare condition called vasculitis. And so I probably picked the hardest study
straight
to do.
In the deep end.
Yeah, straight in at the deep end, but absolutely loved it. And it was really interesting because for me, these patients present anywhere in the hospital. And it takes about 6 months to get a diagnosis of vasculitis because it's a really unusual condition. And on average, it takes 3 different consultant teams to make that diagnosis. So one of the things we had to do was say, well, although I'm a kidney specialist, these people might present to ophthalmology, or they might come into ENT or rheumatology. How are we going to make sure that we give research opportunities to all these patients? So I went round all the different departments for the 6 months before the trial opened. And really interestingly, only one of the patients we recruited was from the renal team. The rest came all the way through the different departments, and actually then led to us setting up a sort of group that was a specialist regional service for vasculitis. So yeah, it was really interesting for me. I have not yet met a patient who doesn't want to hear about research.
Really? That's interesting.
Yeah, I think it's always, you've got to pick your timing.
Yeah.
But, actually, people are really interested in what opportunities are available for them with their medical condition that they can take part in.
Yeah.
And even if they don't want to take part, they want to know what's happening, because it gives you hope for the future in terms of new treatment options.
Yeah, previous conversations that we've had on the podcast is that the patients are very keen to be part of the future, and even if it doesn't impact on their actual treatment pathway, I think just the fact that they're being involved in research I think it makes them feel good and part of something. So it's really interesting that you've said the same, and I think this will lead in fairly well, because I'm very keen to hear about your clinical director role, but we can maybe touch on that a little bit later, because I first met you as the R&D lead at South Tees, and you've obviously done many trials at South Tees and at Newcastle, and through your donation work. So I guess is there any particular trial or study that really stands out and you're the most proud of?
I think the thing I'm the most proud of is where I wasn't actually leading the trial, but a colleague was leading the trial.
Yeah.
And this was a trial trying to understand how we provide equity of access to living kidney donor transplantation. So when I started as a consultant in 2011, there'd just been a publication that showed that if you were in the catchment area of a transplanting centre, you were more likely to get transplanted than if you weren't. And if you came from a poorer area, you were less likely to get on the transplant list. I'd started a non-transplanting centre in lots of areas that are got deprivation in South Tees. So for me, I was like, well, hang on, I'm starting here. And one of the things that I started was they asked me to set up a live donor service. And I thought, look at these two publications and you sort of think, well, how are we going to do this really well? So what I did is I met with the nursing staff that were sort of working with patients, and we interviewed a whole series of patients about what they would want from living donation. And so you've got the recipient, who's the person that's going to receive the kidney, and then you've got the potential donor, and you need to listen to both sides of those stories. And so I listened to both sides of those stories, and we designed a one-stop system which reduced the number of visits, where you could know at your appointment when you had to come next time round. It was much more efficient, and it reduced the workup time for donors by a third, and it enabled the number of visits to go from 12 to 3. And if you're on a 0-hour contract, or you've got young kids, or you've got problems with getting away from work, then actually that really matters.
Absolutely.
And we were able to impact significantly on the number of live donor rates, so that we were actually highest in the country about 5 years after the service started. And over that period of time, a colleague in Bristol called Pippa Bailey was doing some qualitative research work on what are the barriers to living kidney donation. And I think it was 2018, we both presented at a UK national meeting. And she presented the research findings for what are the barriers to living kidney donation. And I presented what was the clinical experience of working in a deprived area, trying to maximise the service. And what was the amazing thing is that we touched points, I'd kind of identified through clinical practice, she'd identified through the clinical research trial. And then you're able to combine those things to change government policy.
Yeah.
So for me, it was actually not a trial that I'd led that I'm probably most proud of. It's the clinical service, but working with a colleague who was leading the clinical trial. So you've got that fantastic dovetail of research and clinical practice evidence that you can put together to change practice.
That's really interesting, because a question that I had for maybe later on, but you've touched on it now, is that a major theme of the podcast of this series has been how research can tackle health inequalities. And so that's a real fantastic example of how research is impacting the policy and targeting the communities that we're trying to serve, I guess. I suppose, have you got any other examples of how maybe do you think
research in the future can really start to tackle these different health inequalities. And the Northeast as a whole is very diverse in terms of income. And how do we start to break down the barriers to getting everyone involved in research, do you think?
There's a couple of questions in there, aren't there?
Sorry, Caroline.
No, don't worry. I think if I, again, think of a couple of examples, I think in terms of how we can use research to tackle inequalities, there's two areas. The first one is that we need to make our research accessible, and we need to put research where the disease burden is highest. Yeah. And if we are doing that, we're maximising the research opportunities for the group of people that need it most. Yeah. The second one is actually to target research specifically around how we prevention, essentially. So we know that, and an example, if I go back to Middlesbrough, when I was R&D director at Middlesbrough, it had the highest preschool morbid obesity rates in the country. And I said, as I was thinking about R&D, if we're not paying attention to what's going on in our community, we're not going to see this kind of huge disease burden that's going to hit the trust in 20, 30 years' time. So it's something really interesting about you're not just got the problems of today, you're looking at what are the problems that we're going to be faced over the next 10 to 15 years, and how do we try and reduce those and impact on our community earlier so that outcomes are better. And then just to go back to the sort of two examples, I think when I went back to, if I think just about COVID studies for a moment.
Yeah, that's a big one.
The recovery trial was a really, really interesting one. And we know that in the Northeast and North Cumbria, patients were more likely to do worse in COVID because we had higher levels of deprivation and poorer health outcomes.
Yeah.
We worked really hard across all the trusts collaboratively to learn how we best recruited patients into the recovery trial. And that was really good collaborative working across all the trusts. So they shared what worked and what didn't work. And we actually had the highest percentage of recruits in England into the recovery trial. So 13% of all admissions that came into hospital were recruited into the recovery trial. And that was through recognising that we each have different skill sets and actually learning across the system to influence that. So I think that's a really good example of that.
Yeah.
I'm mindful of, so I also look after haemodialysis patients, and I did a commercial clinical trial that was looking at a new form of treatment for anemia. Now, if we look at the history of anemia, and this is a fantastic sort of research story, before we had treatment for renal anemia, patients used to have a hemoglobin of about 50 or 60 and normal's 120. So it's a bit like going around just really tired all of the time. And they had poorer health outcomes. And we tried not to transfuse them because then they would form antibodies to any future organs. And then commercial companies were able to come up with a drug that's a synthetic version of the hormone that your kidneys normally make called erythropoietin. And when I first started as a renal trainee, we had to administer it as an injection a couple of times a week. And then they worked out that if you change the structure of the chemical, it will last longer in your body. And then they did trials around that as I was training. And so by the time I was a consultant, people were on sometimes monthly injections, but they were still injections. And then looking at all the science of this, they were able to find a tablet alternative that acts slightly differently along the chemical pathway. And so what I was doing in this trial is I was working with our haemodialysis patients just to try tablets instead of injections. And the patient that I was working with on this had 3 failed transplants and had been, so he was probably about 6 or 7 when he first got kidney failure, and he was in his 50s when I recruited him to this trial. And just his understanding of the anemia treatment, how it massively transformed his life as a teenager, and then the different treatment options for his anemia. And he responded really well to this tablet. And we were able to maintain his blood count without needing any injections. And he was really thrilled to take part in the study. And it had been about, I think, the 3rd or 4th study that he'd taken part in.
Fantastic. I think that's a great example. I mean, there's numerous studies about how hospitals and trusts that are research active do produce improvements in patient outcomes. And it's for that exact reason that clinicians like yourself are at the cutting edge of new treatments coming through and can deliver the best for the patients, I guess. And I'm delighted that you touched on the recovery trial as well, because we spoke to Dr Ben Prudon, who was the PI at North T. So So listeners that enjoy this conversation, maybe go back to the Dr Ben Prudon one as well, who discusses the pathways for the recovery trial at North Tees. The next question for me, I guess, or the next discussion point is the O'Shaughnessy report came out at the end of May, and for listeners that aren't familiar, it was just a review into the commercial trials process in the UK, and you'll be pleased to hear that I'm not going to ask you to go through the full report, Caroline, but the NIHR welcomed the objectives and the aims in the report, and they also highlighted the transformational change that is already underway. So how we're trying to make it easier for patients to access research, and you've already touched on a little bit about that, and how we design the setup of studies to be a little bit more efficient. The area I'd like to focus on, if I may, is the strengthening the research workforce. So many conversations that we've had on this podcast are people from dedicated research teams or individuals like yourself who really drive research in your speciality. How do you think we reach a point where the wider clinical or non-clinical workforce in trusts kind of see research as just routine, day-to-day part of their role?
I think so, and I'll speak from my kind of experience.
Thank you, Carol.
I've only once in my life had a clinician put his hand up in my face and went, "I'm not talking to you about research, Caroline, so stop trying."
Right.
And if you think about how many thousands of conversations I've had over the last 20 years,
absolutely.
That's not bad.
No, it's not. Yeah.
And even that, we were able to. So I walked with him down the corridor and I said, "Okay, let's not talk about research. Let's talk about quality improvement and how." Because I said, "I know you want the very best for your patients." Absolutely agrees with that. And you won't find any member of staff in the NHS that doesn't agree that they want the very best for their patients. So I think it's about showing how research can impact people. I think traditionally think that research has to be done by very clever people in very special environments. But actually, it's about showing how we can embed it in every bit of the kind of care pathway. And I think that's really important. We need to see it as standard care.
Yes. No,
it's the very best standard care that we offer research opportunities. And when I was in renal medicine, there's quite a broad set of specialties. So we talked about transplantation, there's hemodialysis, there's peritoneal dialysis, there's outpatients, chronic kidney disease, the rare diseases. So there's this whole spectrum. And as we were growing our research team within South Tees, we looked at these clinical areas with a specific aim of how do we offer research opportunities across the spectrum so that if people want to take part in a clinical trial, they can. And the specialist nurses who don't traditionally have research in their job descriptions are all really interested in research, in my experience. Yeah. And when you share with them what trials we could do and support in their clinical specialty, they are supportive of that. And, over the sort of 5, 10, 15 years that I've been involved in research, we're seeing an increasing role in our allied health professionals leading clinical trials, being a principal investigator. There was a study called RADAR, which is Renal Rare Disease Registry, which we were only running in South Tees. And I said, well, we go into County Durham and Darlington to do hospital outpatients. We go into North Tees to do hospital outpatients. So how are we going to work to offer research opportunities to all those patients? And what we did was we set up a system where I was a sort of supervising PI, and then we had a nurse PI for that site. And each of the outpatients became research active, and we were able to recruit patients into that trial. So I think it's thinking innovatively how you reduce the barriers for staff engaging in research.
Yeah, the big thing for me, and not just saying this because you're speaking to me today, but I think the fact that you do think like that and that you do approach, your peers and your colleagues and you think in those terms, I think is really beneficial. And I know the Trust Improvement Plan at South Tees now explicitly states that research is part of our objectives. From my personal experience when I was the pathology facilitator at South Tees, is that some of my colleagues still saw it as burden or something extra. So there's a big piece of work, I think, with just engaging with everyone a little bit more, and I hope maybe podcasts like this will do that. But I still think it takes like an inspiring individual to maybe break those barriers down. Do you think?
Yeah, I think so. I think there's also something about when hospitals are incredibly pressurised,
100%.
especially now, even more so, I think, after COVID.
Yeah.
And it's really important that research the funding for research goes to the right places. So for support services, there is money allocated in clinical trials.
Yes.
And it's really important that that is recognised and given to the department and used to support that research. A lot of the time you end up having conversations about money and resource, and it's people, time, resource. And it is really important that those who are engaging in research are seeing that benefit come in terms of the remuneration. Because you're right, you see the benefit for patients and you will push for that. But it's really important within a busy department that service is funded appropriately.
Definitely. And I think that the benefits for the whole trust and individual staff members who do get involved in research, I think it is. I mean, I'm very much a convert to research, so the benefit to me personally, benefit to my teams. It's been fantastic to be involved in research. But this might be a good segue to discuss your clinical director role at the NIHR in the northeast North Cumbria. So we're sat in the offices right now. There's lots of projects going on, lots of initiatives, and it's a very, very busy environment. So I guess, can you tell us a little bit about your role and then, in your opinion, maybe the future of kind of northeast research, and maybe in the next 5 or 10 years, maybe, Caroline?
So I'll tell you a little bit about what I do. So as clinical director of the research network, I have both an internal, external sort of facing role. Internally, we have a fantastic team that works across the region. I support Morag as the Chief Operating Officer and Chris as the Deputy coup, and Alan to work with those teams and deliver the role of the Clinical Research Network. Yeah. In terms of externally, I have 2 roles. So I work with the National Coordinating Centre, contributing into the kind of leadership of the national CRN. I also do, I have done a couple of additional roles that they've asked me to, one around Research Reset and the other one across NIHR Programme Board for underserved communities. And then you've got the regional role. So the Clinical Research Network sits within a community of kind of bits of research infrastructure and organisations across the Northeast. And there's a real significant role of the CRN director kind of working across those systems, getting to know the pressures. I always think the quality of your listening is really important when we go out and we listen, because the pressures in Carlisle are very different to the pressures in South Tyneside and Sunderland. The challenges in primary care are different to the challenges in schools research, are different to the challenges in neuropsychology research, let's say. So it's always about listening to the narrative that you're being told and then seeing where the CRN can add value. And for me, it was it was a really interesting job role to consider, and I really like the fact that it covers research everywhere.
Yeah.
I've got a background working with the National Housing and Homelessness Charity that has really helped me understand the value of research in that setting. And, I've worked with them over the publication around universal credit, came through supported work from the charity, and more recently a challenge around providing the appropriate training around trauma for those who work with homelessness people. So there's a really interesting spread for me, and I love the diversity of it. And I also, although I'm a secondary care physician, I totally understand that the problem is far earlier and far bigger.
Absolutely.
And ultimately, I want to be able to influence the system to make the very best for the majority of people. And if you're the person in the neurophysiology clinic with the rare condition, that's really important that you get that research trial. And if you're the person sleeping rough on the street, not knowing how to access healthcare, you really need that psychological support and a key worker to help you with that.
Yeah. Again, a theme from the past 4 or 5 conversations of this series has been about this holistic kind of early intervention to take the pressure off further along the line. And I suppose everyone is aware of the need to allocate resources equally and in an equitable way to increase this early intervention. Do you think right now that is possible, or is it kind of a long-term strategy to maybe increase the way that we reach patients earlier?
So I'm conscious by that question. I didn't answer your question about the Northeast over the next 5 to 10 years, but they kind of fit together.
It kind of links, I think.
Yeah.
Hopefully, yeah.
So if you want to impact on things like life expectancy, you're going to have to put 20, 30 years of quality infrastructure, funding, resource in. And you won't actually know which bit was the bit you did, which bit was the bit the council, who are doing incredible work over this, which bits of this the education team are doing. So I think, yes, if we're looking at those longer term impacts, they take time and we contribute to them. We don't deliver them by ourselves. Absolutely. But in terms of where I see research going and how to make the biggest impact, I think there's 2 things that we really need to focus on. We do some stuff really well already, and we need to do more of that. We are exceptionally good in our region at particular types of clinical trials, particular specialist areas. There's the new digital trials that have come in that have been done in the Northeast and North Cumbria. So there are some real research strengths, and we need to focus on those and carry on supporting those teams to deliver that. Then there's looking at where are the kind of grayer areas where there's lots of disease burden, but we're not getting there, either because we're not getting there by geography, or we're not getting there because we don't have enough investigators in that area. And how can we support early chief investigators develop their career, get appropriate mentorship, support, linking in with other clinicians that might be research active in that area from elsewhere in the UK to really drive research into those needs. And then just really paying attention to what's going on in terms of prevention studies and how we can engage fully in that.
Now, that's really interesting. Again, the collaboration that you spoke about between, say, the health service and the local councils and maybe universities and academia, something a bit separate. But I did a piece of work recently looking into how the competition policies of the last 20 or so years has now made it really difficult for collaboration that is now needed for this huge transformational change. I won't keep you too much longer, Caroline, but one of the last questions, I guess, is have you experienced any barriers to collaboration? How have you how have you eventually got around that and got people on board?
So yes, I think there's sort of different levels of barriers. First one is sometimes knowing who to ask.
Yeah.
And you can put so much energy into asking the wrong people and then just feeling that you're not getting anywhere. So I think find someone who's helpful and can listen to what you're trying to do and get some advice from them. And you know, I'm always happy for people to approach me. I quite often redirect them to a member of my team, but I'm, more than happy to do that. I think it's really important to get someone within your own specialty or your kind of profession, because then you really see and understand how someone's made it through different bits of that career progression. So yeah, find someone to get some good advice from, I think. And then the second one sometimes is that the people you want to collaborate with may not want to collaborate with you because sometimes there's competing. So if someone's got an idea and yours is quite similar, they might not want to. And sometimes you can just ask that question directly and it's much easier to. So I remember there was a particular methodology we wanted to borrow from another team looking at kidney volume in CTs, and they didn't want us to use it because they were going to use it in a particular trial. So even though we were using it in a really different context, and then it's a bit of a hiding to nothing, and there are some things you just have to go, okay, that's fine. Yeah. We'll put that to one side and try another tack. I think there are two things that really, really make a difference. The first one is you've totally got to own, understand and breathe the value of what you're wanting to do, because you need to be able to convince people and understand them, and help them understand what it is you're trying to do, and take every opportunity to talk about that. And the second one is be persistent. So I think when I first wanted to go and do research, I was quite an unusual person. So I was a part-time woman, and this was it was early 2000s actually, but still I'd kind of gone to this research funding interview, 36 weeks pregnant. And a fire alarm went off just before my interview, and we were up on the 5th floor and we all had to climb down the exit. And so all of the interview panel that I hadn't met before were helping me down the steps, and they helped me up the steps. And then the third question was, if we award you this funding, what will you do in the first month? And I looked at them and they looked at me and I thought, well, yeah, I'm going to be giving birth. And they were very polite, and they, but I think things have shifted for part-time women and for parenting, which is great. But persist, because I did keep persisting. So I didn't get that bit of funding, but I did get funded to do my PhD. I was able to do my PhD part-time. I had maternity leave in the middle of my PhD. I did all sorts of things that I wouldn't have thought would have been possible. And you have to kind of develop a little bit of a thick skin, because I remember, these are anecdotes, so please edit these out if I have too many anecdotes. But I when I decided I wanted to do research, I went to see, there were about 3 or 4 professors in Newcastle in specialist areas who I could go and talk to. And so I'd done a couple, and then I went to see, it was the first one I went to see because I hadn't done my proper homework, hadn't looked at all his publications. So it became pretty obvious within the first 10 minutes I hadn't done my homework about what it was that I was going to be potentially working on. And
a bit like me today on this interview.
No, but about 4 years later, when I was then funded, they gave a lecture on how to develop a research career, and he was one of the speakers, and he gave an anecdote of what not to do, and he literally described the interaction with me. And I was sitting sort of 5 or 6 rows back, and I didn't know whether to laugh or just slide down off my chair. And I don't know if he recognised that it was me at all, but it was one of those moments where you go, okay, I should have done that so much better, but you just learn for next time. And people will respect your resilience and your learning and your adaptation.
Amazing. And I think another trait is maybe passion. And I think your passions definitely came through for research today. Very final question for me, because I know you're very busy and I do appreciate your time today. You've had a fantastic kind of career today with lots of different roles. I guess just a kind of personal question is there anything you think you would still like to do and you haven't yet done in research?
Yeah, I think it's quite interesting when you look at, within the renal team, what I like to do is build research systems and try and influence and tweak the system so you get best performance. I've done that within a small team in renal. I've done that within the R&D team at South Tees, and now within the Clinical Research Network. And I can already see that there are some things that you want to change nationally because you can't change them regionally. But it's really interesting. I think sometimes you don't know if you're going to be any good at something. So I think part of it's been quite interesting to try a few national things to say, well, would I actually manage to do that well? And again, it goes back to the quality of listening. The more that you can listen and observe, which for me is quite painful because I love talking. So I actually have to actively practice not talking and listening.
Perfect guest for a podcast.
So it's what can you contribute to? I mean, I think there's loads of stuff to do regionally. So, that I would, I am enjoying what I do and I love this. And I'm still doing a little bit of organ donation research and transplantation research and really want to support that community develop. Yeah. So
fantastic. So there's going to be plenty on the horizon, but it's been a fantastic conversation. You've got tons going on. It's been an absolute pleasure. Thank you so much for your time, Professor.
Thank you for listening. If you are as inspired as I am to learn more about Professor Wroe's work, please visit the National Institute for Health and Care Research, North East North Cumbria website at nihr.ac.uk/LCRN/NENC. The Living Kidney Donation Network can be found at odt.nhs.uk, where there is a dedicated section for living donations. For the Oasis Community Housing Organisation and Charity, please visit oasiscommunityhousing.org. For the current and future Series 3 episodes of A Blind Date with Knowledge, please remember to hit subscribe on the Spotify page, where there is also an option to leave any feedback or questions that you might have for me, Craig, Laura, or any of the guests. Series 1 and 2, including the COVID-19 recovery episode, can be found by searching A Blind Date with Knowledge on the Alitu podcast platform, that's ALITU, or on YouTube. As ever, thank you so much for listening. Take care and we'll see you soon.